our next speaker, Dr. Niall Corcoran. He's a urologist working at Royal Melbourne Hospital, Frankston Hospital and the University of Melbourne, and he's going to tell us about DNA sequencing. Please make him welcome.
Thanks very much, and thanks very much to the organisers for the invitation to speak. So I'm just going to give a bit of an overview of some of the research we've been involved in and sort of the direction in which we're going in terms of what we're doing in the prostate cancer space. As you guys are doubtlessly aware, there's a lot of problems with selecting patients for treatment for prostate cancer. We know that the majority of men have reasonably indolent prostate cancers, and even without treatment, they won't die from the disease or won't experience morbidity or mortality from it. But also there's a sizable number of men who will progress, so they do have aggressive cancers. It will spread and it will cause premature death. So we have a real difficulty in the clinic identifying these men and selecting out those who will do badly versus those who will do well. And because of that, we often cast our net very widely and overtreat a lot of men and expose men to unnecessary morbidity without a reasonable expectation of benefit. We know that men who do die from metastatic treatment-resistant disease. And the other concern we have or the other major research interest we have is how do we optimize treatment for these patients early on in the disease to sort of maximize cure rates and maximize the ability for long-term control. And this is where the DNA comes in. So every cell in your body, pretty much, bar red blood cells, have DNA in them, and it's in a little bit of the cell called the nucleus. And DNA acts as a recipe book or a code book for the cell. How it's made and how it functions. So it's got lots of different instructions in it, and the particular set of instructions a cell will follow depends on what type of cell it is. So in a bone cell, they turn on all the bone-related DNA, and in a prostate cell, they turn on all the prostate-related DNA, and they switch off everything else, so they don't have any identity crises. And really, cancer, across all different cancers, is a disease of DNA. So when you get alterations in that code, so you might get a mutation, or you might get a gene that usually there's only 2 copies of, but suddenly it becomes amplified and you got lots of different copies of it. Or you got genes that should be turned off that are now turned on, and you get conflicting instructions. That's where cancer arises from. And if we think about cancer, we think about what are the hallmarks or the behaviors that we can say that's a cancer and that's not. And they are really uncontrolled cell growth. So growth is occurring without any kind of checks or balances that say, okay, you've grown enough. They become resistant to cell death. So, cells dying or attrition is a normal part of physiology. So your skin replaces every 5 to 7 days. Your gut replaces every 3 to 4 days. They sort of do their job. They die. They get shed. Similarly with prostate, but the turnover is a lot slower. It's usually months to years. But cells that get these changes in their code book can resist cell death, and so they not only are they turning over, proliferating uncontrollably, they're also not dying off. And then they develop the ability to invade, so to transgress tissue boundaries, to move outside their normal space where they live. And then eventually they develop the ability to spread to other sites. So not only are they content to grow in their own area, they develop the ability to get into the bloodstream or into the lymphatics, move to other sites and lodge in a secondary site and then grow. So the first whole human genome, I was just checking there what the cost was. So the first whole human genome was sequenced in 2001. So it was done by the NIH, and it cost $3 billion, and it took 15 years to do with multiple labs around the world. So massive undertaking. It's the biggest international global collaboration in any of the biological sciences. So it was absolutely massive. In the intervening 17 years, things have come on exponentially. We can now sequence a human genome in 3 days. We can do it for about $4,500 for a tumor and about $1,500 for a germline. And that's because of the availability of new technology and new machines that were all developed as part of the initiative. And basically what it does is that you generate basically a long list of letters, which is the code of DNA. So there's only 4 letters in the DNA, and they're arranged in different permutations to give you the entire code. So you can put it on a sequencer, and then you can read the sequence. And basically you read T, C, G, A, T, the various bits that make up the code. And so what does that allow us to do? So it allows us to identify changes that are important in cancer development. So we can take a normal piece of tissue from a patient and a piece of their cancer tissue, and we can ask the question, well, what's different in the cancer compared to the normal? What are the changes in the code that are driving cancer in that particular patient? We can also identify then, or ask the question, what causes metastasis, or what drives metastasis? So we can take a piece of the bit that's spread and the bit of the tumor that's still there and ask, well, what's different between them? What's different in the code? And similarly, we can ask the question, what drives treatment resistance? So we take a piece of tissue beforehand, we take a piece of tissue after, we apply sequencing and again ask the question, what has changed in the code that may be driving resistance? And so first we're going to deal with what are the changes that are important in cancer development. And this was a project, again, it was an NCI-funded project that we were involved in a few years ago. And this was, again, an international collaboration of various sites, North America, Europe, Australia, South America. And we looked at 333 tumours derived from patients with localized prostate cancer. So they'd been diagnosed with prostate cancer, they'd gone on to have a prostatectomy, they'd opted for surgery as their curative treatment. And we've taken samples of that tumour and basically sequenced it at lots of different levels. So we could tell at various different levels in the code what was different and what was different compared to their normal tissue. And about 70 patients from Australia were included in this analysis. And this is a very complicated slide which doesn't say a lot. And unfortunately, that was the upshot of this study. So we were able to classify cancers. We were able to say, okay, if we look across all the cancers and we look across all the different things that are driving it, basically we could see that there were 7 different subtypes, okay, which accounted for about 76% of all cancers. So we could say these were early events that occurred in these tumors that were driving the cancers, okay? But we couldn't say they were associated with anything that was important clinically. So none of them were related to things like the Gleason grade. So what did the tumor look like down the microscope? None of them were related to clinical stage or pathological stage. And importantly, because this was a large American study that had limited funding, we had nothing of, we had no outcomes. So we weren't able to say, okay, if you have this alteration in your tumor, you were more likely to recur in the next 5 years and you might benefit from extra treatment up front. Or if you've got this type of aberration, you're going to be cured just with your surgery alone. And so we didn't have that sort of information. The second thing I'm going to touch on, and this is something that we've driven here, is how do metastases arise and what drives them? And this is what we think, or this used to be the standard model up to about 5 years ago, about how metastasis develop. So we think about a cancer almost like a growing sphere, okay? And so you've got these early cells in the middle, and as they divide and develop, the sort of outer layers of the onion get bigger, and as each layer progresses, they develop new changes, and eventually those new changes allow a cancer cell to invade another organ, or to invade into the bloodstream and circulate around and then lodge in another site and grow. And it's this sort of linear, stepwise accumulation of mutations or changes that we think of as the standard linear evolutionary model of how metastases develop. So this is a patient that we did that we analysed in 2014, and this was a guy in his 50s. And he presented with an elevated PSA of about 8. He had a high-grade tumour on his biopsy, so Gleason 4 + 4 = 8. and he underwent a radical prostatectomy, and this is, I don't know if you can see this. So this is his PSA down here. So after his surgery, his PSA became undetectable, and he remained there for a period of time. Okay, after about 2 years, he started rapidly developing some symptoms. So he couldn't pee properly. He sounded like he was obstructed, and he also developed some pain in his ileum and his sacrum. At that stage, we did some investigations and found that he had a local recurrence. So when you do surgery to remove the prostate, you make a new join between the bladder and the urethra, which is the water tube. And so he had a recurrence. So he had recurrent tumor at that anastomosis, at that site of join, okay, which was obstructing his urinary flow, which we resected. We also checked his PSA, and his PSA, instead of being undetectable, which it had been a few months ago, was now very high. It was nearly in the 90s to 100s. And so we organized some investigations for him, and he had a bone scan which showed widespread metastatic disease, bony metastatic disease. And 2 sites in particular lit up, one in his sacrum, which is the bit of backbone at the very end, and the other in his iliac crest, which is the hip bone. And these are 2 common sites of spread for prostate cancer. And so once he was diagnosed with this, he was started on treatment, and the standard form of treatment for disease that is spread is a thing called androgen deprivation therapy, where it's a treatment to lower the testosterone in the body. And so we started that on him, and he seemed to stabilize, but only for a couple of weeks. And after about 6 weeks, he began progressing again, and his PSA started to climb, and he developed pain. So before he started treatment, we took some biopsies of the metastasis in his sacrum and his iliac crest. And after he started progressing again, 6 weeks later, we also took some samples. And what we did was we sequenced all of these tumors. So we had a sort of a longitudinal collection of tissue. So he was kind enough to donate his tissue at the time of his radical prostatectomy 2 years previously. We had his germline, which is his normal tissue, and then we had the various metastases that occurred both pre and post treatment, and it allowed us to do some sequencing. And when we did that, we were able to compare how similar DNA from a particular site was compared to the other sites. And based on the degree of similarity, we were able then to develop sort of a family tree. So who was related to whom, who was evolved from whom, okay? A bit like a family tree. And the first thing we noticed about this guy is that when we looked at his primary tumor, so he had a pretty small primary tumor. It's about 0.4, 0.5 cc. And I said at the start he was Gleason 4+4. He actually wasn't. He was 4+3. When we looked at the tumor, the bit that we thought would be the origin of his metastasis, so we all assume it would be the high-grade element, the Gleason 4 pattern. When we looked at his Gleason 4 pattern, we found that it was not related to his metastasis. We had to go back to the prostatectomy specimen, dig out the Gleason 3 component, and when we looked at the Gleason 3 component, it was actually the Gleason 3 component that was the site of his metastasis. That was the bit that spread. The next thing we did is that we looked at his local recurrence. So we then said, okay, this local recurrence, we think of it as being a sort of a failure of local treatment, so that when you have your treatment, you can cut through the tumor, or the radiation may not reach it, or whatever it happens to be. And so we associate local recurrence with primary treatment failure. But when we looked at his local recurrence, we found that it wasn't particularly similar to his local tumor at all. In fact, it was more similar to one of his metastases. And so what we think has happened is that his cancer has moved to another site, in this case his iliac crest, and then has come back to the site of his join. So the thing in his local recurrence, as we call it, because it's anatomically correct, is in fact a metastasis back to the site of his previous tumor. This was the other interesting thing. This is a comparison of his tumor in his iliac crest pre-treatment and post-treatment. So when he had pre-treatment, he had this clone, which was called clone D. So they were all given different letters. But this was the predominant clone in his iliac crest before he started treatment. He went on androgen deprivation therapy for 6 weeks. We resampled it and re-looked at what was there. And we found that the clone that was originally there had completely disappeared. So it was no longer present. he had 2 new cell populations within that site, okay? One of which was an evolution of the original tumor that was there. So the cancer had evolved, had changed in that period of time to become resistant to the treatment. But also he had a second cell population that was actually derived from the other site that we had sampled, the sacrum. So it looked like the tumor that he had in the iliac crest was sensitive initially to the treatment. The tumor cells disappeared, but then they got replaced by 2 sites, one from the sacrum. So the cells said, okay, you're vacating that space. I'm going to jump in there because it's sort of a sort of set up for metastasis. And also he had a smaller component that was derived from the original cancer that had evolved in that 6-week period. So it was moving quite quickly. When we looked at across the men that we sequenced, we did this in a number of different men. When we asked the question, is there anything that is common to all of these cancers that spread compared to their local tumor, we found 2 things. One is that they all the metastases pretty much had mutations in this particular gene called TP53. And TP53 is the most studied gene in the entire history of mankind. Yet we still don't know everything about it. And this was a new finding in that one of the functions of TP53 is to control cell fate. So if you get damage to your cell, TP53 acts like a brake, and it says, stop dividing, we'll try and repair it. If you can't repair it, then the TP53 will tell the cell to kill itself and eliminates it, okay? When you get these mutations in TP53, it makes it inactive. So it's no longer able to put a brake on the cancer cell, and it allows errors in the code to continue, the cell to continue to divide despite having errors in its code. The other thing that we saw that was very common was that the metastases often had errors in their repair system. So, we replicate our DNA. So the DNA is like 3 billion letters in a row. And when we need new cells, we've got to replicate that DNA. And it's an error-prone process, as you can imagine. Trying to copy 300 or 3 billion letters with high fidelity or faithfully is very difficult. Also, your normal cell is subjected to various stresses. Various stresses. Things like UV radiation can cause damage to your DNA. And so there's a highly conserved repair mechanism within each cell that spots errors in the DNA and repairs it. The other thing we noticed in these cells is that in these tumor samples, that they all had errors in their DNA repair process. So you combine the 2 things, you get a defect in your error repair, and you got a defect in your brake that normally allows stops cells with defects from proliferating, and that seems to be the secret recipe for metastasis. The last thing I want to touch on is, why do tumors respond differently to treatment? And I've only got a couple of minutes, so I'll quickly go through this. But this is how we standardly think of how resistance develops. We know that cancers are a mixed bunch of cells, so it's not just one tumor cell population, there's often very many, okay? And we think that within each tumor, there's a bunch of cells that don't divide, and they are intrinsically resistant to stress. So if you apply a stress, and that could be hormonal therapy or chemotherapy or radiation, it kills off the sensitive cells, but the resistant cells remain, and that they eventually then can repopulate the tumor. And this is what we think is the basis of treatment resistance. So we were wondering if this happens in prostate cancer. And so this was a trial we did a few years ago where men with high-risk prostate cancer, as defined over here, were treated with hormonal therapy for 6 months. And basically we took out the prostate to see what happened. Seems to want me to stop.
It's because you've put the word super castration up there.
I did.
And there's just a feeling in the room, don't you think? I think the patients have got the numbers, their wives are here, and they're saying, get rid of that word.
Look, I didn't want to use it. Ben Tran told me I had to. and every patient that we had on the trial, if we measured their PSA became very low. But when we actually did their surgery, we saw that there were marked differences in treatment response. So There was a bunch of guys who did very well, so the tumour disappeared completely, or they're left with very small amounts of tumour. But there were also guys who it looked like the treatment had no effect, so there was still high volume, high grade tumours in their prostate. Unlike what happened in the metastasis, we didn't see any evidence of change in the cell population. So this idea of there being a sort of an intrinsically resistant cell that repopulates the tumour after selective pressure is applied does not seem to apply in prostate cancer. So that links to what we're doing at the moment. So as I said, one of the deficiencies of the TCGA analysis was our inability to link the sort of changes we identified in the code with a meaningful clinical outcome, so recurrence, metastasis, and death. And so we've teamed up with a group in Canada, which we're just putting together at the moment, where we've looked at 550 patients and are using the same sort of approach of whole genome sequencing and identification of various changes, but linking them to clinical outcome. We're also part of a larger global consortium called the Pan-Prostate Genomics Consortium, which includes us, Canada, the UK, and Germany, which are trying to do this again on a much bigger scale, so 2,500 patients. We're also working at the moment on a bigger project about metastasis, a thing called CombiMet, and that's with a German group as well as a UK group. Similarly, looking at patients with paired primary tumour and metastasis to see if we can validate what are the things that are driving it. We're working on a blood test, and this project is close to completion. So as I said at the start, one of the things that seemed to be essential for driving metastasis was a mutation in this gene called TP53. We developed a blood test that can detect that mutation early on in the course of the disease. So even at the time of localized disease, prior to there being any metastases at the time, identifiable on a scan. And so we're looking now in a large cohort of men retrospectively to see if we can link that to outcome. Based on the study, on that treatment resistance study that I talked about, we've designed a new study, which is just going through ethics at the moment, called ADEPT, which will open later on this year. This is myself and Ben Tran, where we're specifically targeting the agent or the pathways we think that are important in mediating resistance in prostate cancer. So I don't do very much work because I spend all my time in the clinic. So all of this stuff was done by Natalie Kurganoff, who's a talented PhD student of ours. She's now in Canada. Mark Samero, who's a computer guy, so he does all the computational stuff at WeHi. My lab partner Chris and Matt Hong, who's a recently graduated urologist who drove most of the metastasis stuff. I'd like to thank our funding. We were very lucky with funding, personal funding from me, from PCFA and from University of Melbourne. But we've also been reasonably successful getting project grant funding. And perhaps most importantly is all the men who for the last decade have allowed us to collect their information, collect their tumour tissue, have undergone painful procedures, particularly the metastasis biopsies, which are not standard of care, and there's no clinical benefit to them for doing it. And so, again, very much thanks to them. We're deeply grateful for their efforts. So thank you.